So, good afternoon, all of you. I hope I'm audible and visible. Santosh and all the other students, please give me a quick thumbs up if my audio video is fine. Please give me a quick thumbs up, Santosh, if my audio video is fine and everything is clear. So, welcome each and everyone. And we are again starting with the same series which we have left a few days back. So, we'll be doing these sessions of must know questions in dermatology. I might move this session from 2:30 to 3 p.m. because there are many students who requested me that the 2:30 p.m. is a little difficult for them to attend. So from tomorrow, I might take these sessions at 3 to 4 p.m. I hope that is suitable for all my dear students. I welcome Basat, Dr. MJM, Melar, Jayur, Tofik, Pradeep, Purnima, Faith, Soumya, then we have Bhavya, Rameshwar, Atul, Salman. Everybody is welcome in this session. Now, till the others join, let me introduce myself. I'm Dr. Chesta Agarwal, your NEET PG educator on Unacademy. And I've myself scored All India rank 261 in my entrance examination. Now, on Unacademy, we give you two type of subscriptions. One is Plus, which give you an access to Unacademy live classes from the top educators. You can have an option of attending the live classes or quizzes. You can study on the device of your choice and you have an access to around 25,000 questions. We also give you printed notes. That is something a very new feature of Unacademy. So if you get a 12-month or longer subscription, we give you printed notes. Now, Iconic subscription give you an access to both Unacademy and Prep Ladder. And with Prep Ladder, you have an added advantage of question bank, video lectures, rapid revision snapshots, treasure notes, dream notes, etc. Clear, everyone? Now we are the new batches which we are targeting this month is a next batch for 2023 exam. This is a 2-year long batch starting on 13th of October. Then we have a NEET PG batch, which we are starting for 6 months. Now, I would recommend all those students, those who, like by any chance, those who have not got a good score or you have missed on some questions or something like that, and if you are trying or you are preparing for the next year exam, I would recommend you to take a 6-month subscription of Unacademy using the code CHESTA10 and get yourself a part of Unacademy platform. This year, we had a 100% strike rate in NEET PG for all the subjects. If I talk about dermatology, from the dermatology subject, you got 13 questions out of 200. So, which is a very, very important weightage from a short subject like dermatology. So, I request everyone to please be a part of it. You can also take part in the Target Next integrated batch, which is for the next to next year exam. Other batches is we have a clinical case discussion batch and instrument batch, which is starting on 13 for 2 months. This is a very important, a clinical type of course where all the practical things will be shown, the instruments, how to use them. They can also demonstrate a few videos, how to perform those tests. So we are beginning with a very important new courses here, and I want all of you to utilize them in maximum. We are also conducting one grand test, or we will conduct one grand test every month till NEET PG or INI-CET or FMG. For FMG student, the free grand test is scheduled for 17th of October, 10 a.m. And for INI-CET, same day at 2 p.m. to 5:30 p.m., the grand mock test is scheduled. So I request all of you to please be a part of this mock test as it is absolutely free. You can use my referral code CHESTA10 for its subscription or its enrollment, as it is free, so you don't need to pay anything. We have highly updated question bank of around 25,000 plus questions, and we have a long list of toppers who have performed very well in their recent exam of NEET PG. So I'm sure that you will also do the same in your respective exam. These are the list prizes for Iconic and Plus. Iconic means Unacademy and Prep Ladder, and here you have 1 year and longer subscriptions. With Plus, you have shorter subscriptions of 3 month and 6 month available. I would recommend all of you to take either 1 year of Iconic or shorter subscriptions of Plus, You can use my referral code CHESTA10 here to get additional 10% discount. There are many students who are actually getting shows the topper list again. Yes, definitely I can show you the topper list again, and RP, this topper list will be given to you. That is attached on your PDF, so you can anytime watch it in detail, or for many you can keep it with you. So what I was telling is, there are many fake IDs which is circulating on the telegram groups. There are many students who got bribed by some of the false IDs, that they are getting more subscriptions, more than 10%. They are claiming that you can get 30%, 40% of discount. So please remember, all of you, that is not true. Unacademy or any of its educator cannot give you more than 10% officially. So please remember, if anybody claims you, that is wrong, and please be very sure before giving money to that patient. Okay, so just be aware, because there are many people, false IDs, which are targeting all of them. Chalo, so we have a lot of questions, and today we are targeting mainly the one-liners. I hope everyone is ready for the today's session. Give me a quick thumbs up if all my dear students, they are ready for the session today. So starting with the first question, I'll give you 30 seconds per question, and I want you all to be a little bit quicker so that you can all answer this question. Starting with the first question. Very nice, everybody. Very well done. Amazing. So a whitish half moon shaped structure situated between the free margin of the proximal nail fold and the nail bed. Please remember the correct answer. Please remember the correct answer is lunula. And can you tell me what is the reason for the whitish discoloration of lunula? Anybody here can tell me the answer? Bindra, Sandra, Shubham, Priya, Muhammad, Pravalika, Raj, everybody is welcome in this session. The reason why lunula is white in color, because you have absence of melanin on the skin which is present below the lunular part of the nail plate. I hope you know that the nail plate rests on the nail bed, and nail bed is made up of skin only. So the part of the epidermis which is present just below the lunula, it has no melanin in them. And because of absence of melanin, the lunula appears white color, and it is half moon shape in appearance. So if this is the nail, you have lunula somewhat like this. Clear with this question, everyone, all the 30 students? Please give me a quick thumbs up if this is interesting and very easy. Next question is on your screen. I think all my plus students will answer this, because we have recently discussed everything in our classes. Very nice. Shubham, Alice, RP, Rameshwar, amazing all of you. Raj, Gouda. Crystalline malaria is due to obstruction of Please remember, the correct answer is option number 2. It is the eccrine sweat duct. It is the eccrine gland duct which get obstructed, giving rise to crystalline malaria. Can anybody tell me what is the site of obstruction in a patient of malaria crystallina? What is the site of obstruction? Melar, then Salman, all my plus students, Ravi. Can you tell me what is the level of obstruction? Very nice, Vedashri. So if this is your skin, and this is the duct of the sweat gland. Please remember, in malaria crystallina, the obstruction is at stratum corneum level. What about malaria rubra, Vedashri? Can you tell me what happens, or what is the site of obstruction for malaria rubra? Malaria rubra, the obstruction is at the level of stratum malpighian, and malaria profunda is at the level of dermoepidermal junction. So malaria crystallina, Melania rubra, and Malaria profunda. Clear, everyone? Please give me a quick thumbs up if this question is clear. All of you, Priya, Mohammed, Pravalika, please give me a quick thumbs up if this question is easy. Chalo ji, very well done. Let's move to the next question. Anybody can tell me the answer here? RP, Dr. Priya, Reena, Lavanya, Purnima, Melar, Bhavya, Atul, Taufik. Very well done, all my dear students. A 40-year-old woman who presents with a 2-year history of erythematous papulopustular lesions on the convexity of the face. There is a background of erythema and telangiectasia. What is the most likely diagnosis? Please remember, a young female or a middle-aged female with the onset of lesions in this age, middle-aged only, without any comedones, presence of erythema and telangiectasia, all gives you an indication that you are dealing with a case of rosacea. How to differentiate acne vulgaris from rosacea? Can anybody tell me how to differentiate acne vulgaris from acne rosacea? Anyone? Can you tell me, Mela, can you tell me how to differentiate between both? Acne vulgaris, you will always see comedone, but comedone is negative in rosacea. What is the age for development of acne vulgaris? Puberty, adolescence, where the age for acne rosacea is a middle-aged individual, male, female, both. Third, you will have history of flushing, sudden increase in the redness, erythema of the lesions when a patient is exposed to sunlight. It is positive in rosacea. When a patient is exposed to sunlight, emotional disturbances, but this history is negative in the patients of acne vulgaris. Clear? Please give me a thumbs up if this difference is clear to all of you. Everyone will give me a thumbs up. Another question is how to differentiate rosacea from SLE. Please remember, in SLE, you will have a fixed redness, fixed erythema that is on the malar aspect known as butterfly rash. But in rosacea, you can see flushing of the lesions or increase in the size when a patient is exposed to sunlight, emotion, or hot beverages. Clear or not? Very, very important. Rameshwar, Santosh, Shrishti, Tariq, Vedashri, AS, Dr. Reena, everyone will give me a thumbs up. So for this question, the correct answer becomes option number 2. These questions are very, very important. Those who are finding them difficult, it's my humble request that please do attend my plus course. I will teach you in detail what are these different types. Amazing. Which of the following diseases are, in which of the following diseases will you see Muir-Case line? Anyone? In which of the following diseases you see Muir-Case line? Taufik, Tarun, Reena, Naveen, RP. Very well done. In which of the following diseases are Muir-Case lines observed? In which of the following diseases are Muir-Case lines observed? Please remember the correct answer is option number 3. What is Muir-Case line? This is an example of leukonychia or vitis discoloration of nail where you see more than one horizontal transverse line, and this is a classical feature of hypoalbuminemia. Can anybody tell me what is the nail finding of cirrhosis known as? What is the name given to it? Anyone? What is the name given to the nail finding of cirrhosis? Anyone? Anybody can tell me what is the name given to them? Very nice. The answer is Terry's nail. And what is the name given to renal failure patient? What is the name given to linear? It is the Lindsay nail or half and half nail. Very, very frequently asked. Lindsay nail or half and half. And Terry's nail is for cirrhosis. Muir line is in hypoalbuminemia, while in iron deficiency anemia, you have spooning of the nail plate known as Coelho line. Clear everyone? Tariq, Vidyananda, then we have RP, Shrishti, Bhavya, all of you. Please give me a thumbs up if you understood. ठीक है जी, आगे बढ़े. It's a very, very easy question, and I hope you all have understood this. You can get these type of questions very frequently in your exam. Chalo ji, let's discuss some other question. In which disease do you most commonly see these hypopigmented macules? Neurofibromatosis, tuberous sclerosis, Barrett's disease, or Haley disease? Very nice. Again, Vaishnavi, Vedashri, Shrishti, RP, Rameshwar, Priya, Soumya, Dr. Priya, Atul, Naveen, very well done, all my dear students. Please remember, these are macules, flat lesions, and they are hypopigmented with lanceolate shape appearance, very, very classical feature of tuberous sclerosis. And what is the name given to them? They are known as ash leaf spot. Now I can see that only 48% of the total students have marked this question right. And on an average, only 50% students are answering it. My humble request to all of you, if you are actually targeting the NEET PG or FMG or INI-CET, it's a very high time when you start preparing on your short subjects. Short subjects carries a lot of weightage, and if I tell you my secret, like how I got rank 261 in NEET PG, the only thing I'll give the credit to is I was masters in my short subjects. So please take an Academy subscription today using the referral code CHESTA10. You can try with the shorter subscriptions of 3 months or 6 months, whatever suits you. Start preparing with your short subjects. The scoring subjects, which is like anatomy, PSM, you have to do complete these subjects as well. So please start preparing. Don't waste much time because you don't have much in FMG or in INI-CET. Okay? And NEET PG also like 6 months will flow like this. Amazing. Chalo, let's go to the next question. Which of the following is the histopathological feature of lichen planus, sawtoothing of the epidermis, civet bodies, Max Joseph space, and all of the above? Amazing. So I can see that all my plus students are right. Okay, RP, then we have who else? Yes, many of you. Bhavya, Lavanya, Melar, very nice. Tofik, Bilal, very well done, all my dear students. So, histopathology of lichen planus is a very, very important exam question. Very, very important. Please remember, this is something which you cannot miss on because histopath of three things in derma is very important: psoriasis, lichen planus, and they can also ask you histopath of vesiculobular disorders. Now, when you do or when you examine it under the 10x magnification, you will mainly see presence of hyperkeratosis without parakeratosis. And can you tell me what is the name given to hyperkeratosis without parakeratosis? Melar, can you remember and tell me that? It is known as orthokeratosis. Very nice, Vedashri. Second is you have wedge-shaped hypergranulosis. Then you have sawtoothing of radial ridges, and you have thick band of inflammatory infiltrate at dermoepidermal junction. Thick band of inflammatory infiltrate at dermoepidermal junction. Next is the stratum basal layer is degenerated, and you form or you see colloid body, civet body, or cytoid bodies, and these bodies get absorbed with time, giving rise to Max Joseph space. So all of the above is the correct answer here. Clear? Anyone has any confusion? What is orthokeratosis? Could not remember. RP, orthokeratosis is the name given to hyperkeratosis without parakeratosis. Whenever you have increase in the thickness of stratum corneum, but there is no retention of the nucleus, it is known as orthokeratosis. Clear? Coming to the next. You can see an image of the ankle, and there are few changes in the skin. You have to tell me pure clinical based question that what it could be. Very nice. Shrishti, Pooja, Vaishnavi, Naveen, Atul. Amazing, all of you. Amazing, everyone. Very well done. Vedashri, Faith, Bilal, Bhavya, Dr. Tarek, RP, Goda, Lavanya, Dr. Priya. Very well done. This is what is known as lichenification. This is what is known as lichenification, which is a classical triad of what? Can you tell me what is the classical triad of lichenification? Increase skin markings. You can see that skin markings becomes prominent. Then you have increase in skin thickness, and there is increase in skin pigmentation. This is known as lichenification, and it is a classical feature of chronic eczema. Clear or not, all of you? Very, very important classical feature of chronic eczema. Oh, very well done. Coming to the next question, vesicles such as sago grains of boils is characteristic of linear IgA, Pompholix, lymphangioma circumscriptum, or none of the above. Or none of the above. Very nice. Vaishnavi, Vedashri, Reena, Vandan, Rameshwar, RP, Jayur, Taufik, Dr. Priya, Vidyananda. So vesicles such as grains of boiled sago or sabudana. Very nice, all my dear students. So please remember the linear IgA disease, Pompholix, lymphangioma circumscriptum, or none of the above. The correct answer is option number 2. Pompholix. It is an endogenous eczema, also known as dyshydrotic eczema, where you see a lot of vesicles or clear fluid containing vesicles which are present inside the skin, giving it a very, very characteristic sagu grain or sabudana appearance. Very, very important questions. You can also get an image based question on this particular type of symptoms. Mainly seen in palm on sole, mainly seen in palm on sole. This condition is due to This condition occurred due to obstructed labor, birth injury, seborrheic dermatitis, or none of the above. Vaishnavi, Rameshwar, Shrishti, Faith, Goda, Purnima, Dr. Tarek, RP, Abdul, Taufik, Dr. Priya, Vandan, Vedashri, very well done. This is what is known as cradle cap. Now, seborrheic gland becomes active only after puberty. But sometimes what happens at the time of birth, the newborn can also develop the features similar to that of seborrheic dermatitis. And why you develop or why the newborns develop this? Because the maternal hormones or the maternal androgen sometimes crosses the placenta and reaches the fetal circulation. And that maternal hormones can stimulate the sebaceous gland function. And that is why you develop seborrheic dermatitis in newborn as well. Clear, all of you? Let's move to the next question. Very, very interesting. A 25-year-old man presented with erythematous rash with burning sensation over sun-exposed areas of 2-day duration after he returned from a beach holiday. Sunburn reaction is caused by which rays? UVC, infrared, UVB, or UVA? Very nice, Vaishnavi, Vedashri, Naveen, Reena, Vandan, Taufik, Shrishti, RP, Purnima. Very well done, all of you. Very nice. Sunburn is because of UVB. And can you tell me suntan is because of which? UVB, UVA, UVC. Which rays causes maximum suntan? Yes, it is UVA. And can you tell me which rays is responsible for skin cancers? Very nice, Vedashri. It is UVC. But please remember, UVC is reflected 100% by ozone layer. UVC you do not find on the Earth atmosphere. It is 100% reflected back. And that is why if they ask you in Earth, which is that radiation in the atmosphere which causes skin cancer, the answer becomes UV. Clear? Bindya, Rameshwar, everybody give me a thumbs up if you understood. Okay. So there are three radiations. UVC is 100% reflected back. UVB is 90% reflected back. Only 10% enters into the Earth environment. While UVA is 10% reflected and it enters 90%. Okay. So that is the difference between the three UV rays or the bands. Oh, very, very nice. If Earth is not mentioned, ma'am, see, if nothing is mentioned, please mark UVC. It has the maximum skin potential or maximum malignant potential. Okay? But if they ask you the question like like they'll ask you that a patient presented to you with the features of cutaneous malignancy, which nerve or which radiation has a maximum potential of causing this condition. So if a person living in Earth develop malignancy, it should be because of UVB, because UVC cannot enter the Earth atmosphere. Understood, RP? Okay, ji? Chalo. So you will definitely get the clue in the question whether you have to mark B or C. Now only 29% students have answered this question. This year we had two questions from the same topic in NEET PG 2021. And I think I have asked this question more than 10 times during my practice sessions. I request all of you, please try to remember the stuff which is asked frequently. The well demarcated lesions on the sun exposed areas in an alcoholic patient. Alcoholic means malnourished. Those who drink a lot of alcohol, they usually do not take a proper diet or a proper meal, and they finally end up into some of the nutritional deficiency. Here it is vitamin B3, that is pellagra. Clear, all of you? Any confusion? Here it is vitamin B3, that is pellagra. Please give me a quick thumbs up if you understood this point. Okay? Please give me a quick thumbs up if you have understood this. Very, very important. Amazing. The next question is on your screen. Shrishti, Shatnik, Dr. Tariq, Pooja, Priya, Vaishnavi, Rameshwar, uh, Melar, Purnima, Jayud, Faith, Bhavya, RP, Naveen. Very well done, all of you. So, look at this question. A 70-year-old means elderly patient with itching, mainly over the trunk or abdomen and proximal extremities. The lesions are tense, surrounding skin is erythematous with no oral erosions and negative Nikolsky sign. Biopsy reveals subepidermal blisters with inflammatory infiltrate of eosinophil. So in this question, you have sufficient hint for making the diagnosis of bullous pemphigoid. All my plus students, please give me a thumbs up if you understood how the answer become option number 4. Elderly patient, surrounding skin shows urticaria or erythema, itching associated with the lesion, eosinophils, negative Nikolsky sign, negative oral erosions, rules out all the other options, and the only correct answer becomes option number 4. Can you tell me why it is not linear IgA disease? Anyone? Linear IgA disease will also present with tense bulla surrounding erythema. Why this is not a case of linear IgA? Anyone? Please remember in linear IgA, first is the age. It is not seen in a very elderly individual. Second is, please remember, you will see a classical arrangement of vesicles. in a patient of linear IgA disease. And can you just recall and tell me what is this? Can you just recall and tell me what is this? This is known as string of pearl. This is known as string of pearl or cluster of jewel or cluster of jewel appearance. Clear? String of pearl or cluster of jewel appearance. Amazing, all of you. Very well done, all my dear students. Very, very nice. Anchoring fibrils are made up of. Anchoring fibrils are made up of. Very nice, RP, Pooja, Faith. Very well done. Anchoring fibrils, please remember the correct answer is option number 1. Now, you all know that we have 3 parts of the skin. This is the epidermis, dermis, and hypodermis, which is made up of fat cells. Now, everybody knows that epidermis is a cellular layer made up of keratinocytes in majority. Dermis is a acellular layer made up of fibers, which are collagen and elastin fibers. The collagen fibers, which are present at the top, at the dermo-epidermal junction, it holds the epidermis to the dermis, and that is why they are known as anchoring fibrils. And the anchoring fibrils is actually nothing but collagen cell. Clear, all of you? Please give me a thumbs up if you understood this point, everyone. And welcome Krishna, Dipesh, Rutvi. Everybody is welcome in this session. Amazing, amazing. Very nice. Now, another point I wanted to discuss is like anchoring fibrils, we have something known as anchoring filament. Can you tell me what is anchoring filament? Anchoring filament is a name given to collagen. So both of these are exam question, and I request all of you to please write it down. Collagen 4 is the component of what? Lamina densa, that is a part of basement membrane. I can see that students are, I cannot see your faces, but your response shows that you are a little confused. I want all of you to please attend my plus classes. I'm sure that the plus students must be finding all these questions very interesting and very, very helpful for their revision. Am I, I think I'm right? All of you, my plus students, I hope you are finding these classes, these questions very, very helpful in your practice. So please try all the other students to attend a plus course so that these special classes becomes more beneficial to you. Allergen responsible for this condition. There's a method or there's a procedure done in this image, and following that procedure you can see something on the face, on the neck. So you have to tell me what is the reason for development of these eczematous lesions in this patient. What was the allergen responsible for this? Very nice, Krishna, Taufik, Naveen, Dr. Tariq, Priya, Rameshwar. This is a hair dye, and the allergen which is present in a hair dye which causes allergic contact dermatitis, it is PPD, paraphenylene diamine. Paraphenylene diamine. Clear, all of you? Paraphenylene diamine. Which of the following is the drug of choice for dermatitis herpetiformis? Drug of choice for dermatitis herpetiformis. Drug of choice in treatment of dermatitis herpetiformis is prednisolone, mycophenolate mofetil, dapsone, or azithromycin. Drug of choice in treatment of dermatitis herpetiformis. Dermatitis herpetiformis. Now, this is a cutaneous manifestation of celiac disease or gluten sensitive enteropathy, where the patient presents to you with multiple itchy erosions on the extensors. Now, the main inflammatory mediators taking part in the inflammation here is neutrophil. And whenever neutrophil comes into action, the drug of choice becomes dapsone. Can you tell me what is the treatment of choice for dermatitis herpetiformis? The drug of choice is Depson, but what is treatment of choice? I hope you understand the difference. Very nice, Vedashri. Treatment of choice is diet restriction. These individuals should be advised not to take bro. They have to avoid taking bro in their diet. And what is bro? It is barley, rye, oat, and wheat. Barley, rye, oat, and wheat. Understood, all of you? Take care. So, drug of choice in treatment of dermatitis herpetiformis is all of them. So, I hope this is clear to everyone. Please give me a quick thumbs up. The next question is BP180 is a target antigen in all of the following autoimmune bullous disease except. Okay, so BP180 is the treatment of choice in all except, your time starts now, mucous membrane pemphigoid, bullous pemphigoid, pemphigus foliaceus, and pemphigoid gestationalis. Very nice, all of you. So BP180 is a target antigen in all of the following autoimmune bullous disease except. Please remember the correct answer is option number 3. Can you tell me what is the target antigen for pemphigus foliaceus? Anyone? Can you tell me what is the target antigen? Vishnu Raj, Rameshwar, Bindya, Tarek, RP. Yes, it is desmoglein 1, which is a component of desmosome present at stratum corneum or below level. Okay? So in BP antigen 180 is the part of basement membrane. You see antibody against BP 180 in mucous membrane pemphigoid, bullous pemphigoid, and pemphigoid gestationalis. But in pemphigus foliaceus, it is desmoglein 1. चलो जी बहुत बढ़िया. Which of the following cutaneous feature of tuberous sclerosis is present since birth? Which of the following cutaneous manifestations of tuberous sclerosis present since birth? Very nice, Melar, Vishnu, Pooja, Taufik. Which of the following cutaneous manifestations of tuberous sclerosis are present since birth? Very nice, all of you. Which of the following cutaneous manifestations are present at birth? Please remember, ash leaf spot is the first manifestation you see in a patient of tuberous sclerosis. And can you tell me which cutaneous manifestation of neurofibromatosis type 1 is present since birth? Anyone? Can you tell me the answer here? Very nice. You're absolutely right, Dr. Tariq. It is the cafe au lait macules. Cafe au lait macule is present since birth in type 1 neurofibromatosis. Very well done, everyone. Regarding dermatophytic infection, mark the correct option. Regarding dermatophytic infection, mark the correct option. And your polls start now. Very nice, Tawfiq, Dr. Bindyananda, Vaishnavi, RP, Rutvi. Very nice, all of you. Very well done. Okay, ji. Now please remember the dermatophytic infection. What is dermatophyte? It is a keratophilic fungus which loves keratin. It grows only over those places which are rich in keratin. And can you just remember or recall and tell me what are the keratin rich places in our skin? The keratin rich places in our skin or in our body is the epidermis, hair, and nail. So dermatophytic is an infection of epidermis, hair, and nail. It is a keratophilic fungus, that is true. And how will you see the clinical lesion? They are annular lesion with central clearing. And if you remember, I've shown you the Images of onychomycosis, if you remember, distal, lateral, proximal onychomycosis. We have white superficial, we have total dystrophic. All these nail changes as whitish discoloration of the nail plate, not the reddish discoloration. Understood? So the correct answer becomes option number C, that is A and C is correct. If anyone has any confusion, please let me know. These are very important questions. And again, I'm requesting that please do attend my plus course. Very, very important. Do not miss this opportunity. Try to attend it. Take care, ji. Very nice. Now coming to the next very important question. Arrange the following stages of doing an auspit sign in order of their time of occurrence in earliest to last. So which is the step 1, which is the step 2. So please solve this question. Your time starts now. Very nice, Vaishnavi, Shrishti, Bilal, Purnima, Vandan. Arrange the following stages of doing an auspit sign in order of their time of occurrence in the test from the earliest to the last. So please remember, auspit sign is a very important bedside investigation which is done in a patient of psoriasis. It's a very important bedside investigation which is done in a patient of psoriasis. Now, the prerequisite for performing an auspit sign is there should be presence of scales, the plaque which consists of scales. Now, second step is you have to take a glass light and you have to rub those scales so that there is accentuation of these scales. So step 1 is A, then you will do grattage, which is the rubbing. What is step 3? When you rub the lesions, they will become more prominent. And when you remove those scales, you will see a thin glistening membrane, which is known as Berkeley's membrane. And when you remove this membrane, you will see presence of pinpoint bleeding areas. So the correct answer is A, B, D, and C. Please give me a thumbs up if you understood this question. Very, very important for your exam. Okay? Dermal blisters are seen in, your time starts now. Dermal blisters are seen in. So dermal blisters are seen in which of the following condition? And I think only 18% of the total students have given me the answer. Dermal blisters means the blisters which are present at the level of basement membrane or below. Can you tell me what is the level of split in Hailey-Hailey disease? Anyone? What is the level of split in Hailey-Hailey disease? Anybody can tell me the answer. Hailey-Hailey disease has suprabasal split. Suprabasal because in Hailey-Hailey you have defective calcium channel which is making the function of desmoglein 3 defective. And desmoglein 3 is present at the suprabasal or basal level. Is this clear, all of you? Vedashri, Tariq, Rameshwar, Prince, Yashi, please give me a quick thumbs up. Very nice. Coming to the next point. Staphylococcal scarlet skin syndrome, it occurs because of infection by Staphylococcus. And here you have defect of desmoglein 1, which is present at the level of subcorneal. While in burn and bullous SLE, you will see the dermal blisters. Clear, all of you? Please give me a thumbs up if you understood this question. And again, I'm requesting that if you're not able to understand this, please do attend my plus courses. Use the referral code CHESTA10 and please do attend my plus course. Very, very important. I can see that majority of you are not able to solve these questions. Okay, you will get these questions in your exam. Okay, chalo. What is the classical lesion of scabies? I think this is a little easy question or a candy question. I am assuming 100% answer here. Very nice, Tariq, Rameshwar, Shrishti, Purnima, Vishnuraj. Very nice, all of you. Faith, Dr. Priya, Vedashri, Aarti, Bhavya, Bilal. Vidyananda, Gauda, Taufik, Dr. Rashmi, Vaishnavi, Yogesh. What is the classical lesion of scabies? Nodule, burrow, blister, and scabella. Please remember the correct answer is burrow. And can you tell me at what level you see this burrow? At what level in the epidermis you see this burrow? Anyone? Tariq, Vedashri, at what level you see the burrow? Yes, the answer is stratum corneum. So this is a track or pathway followed by, or it is a track or pathway followed by the mite in the very nice one of you. Now coming to the next question. Treatment of choice for pediculosis corporis is. Pediculosis corporis is nothing but a louse infestation of the body hair. Louse infestation of a body hair, how will you treat it? 3 applications of BHC, 4 applications of BHC, DDT applications, or disinfection of all the clothes and bedding. Disinfection of all the clothes and bedding. Oh, very nice. Please give me a thumbs up if you understood this. Pediculosis corporis, the louse remains inside the clothing. It does not remain on the body. It remains in the clothing, and that is why the main aim should be treating the clothes. So when you treat the clothes, the mites or the louse will die automatically. Okay? Can you tell me another name for pediculosis corporis infection? Any name given to this particular name? Very commonly asked. Very nice, Rameshwar. Vagabond disease. Vagabond disease. So such a fancy name, okay, like a James Bond or Vagabond. Yes, Rameshwar 007. Chalo ji. Okay. Now coming to the next very important question. Which organism is responsible for erysipelas? Streptococcus, Staphylococcus, Bacteroides, or fungus? Which of the following is responsible for erysipelas? Very well done. Taufik, Tariq, Priya, Vedashri, Rutvi, Bhavya, Vidyananda, Vandan, Yogesh, Vaishnavi, Faith. Very well done, all my dear students. Please remember the correct answer is Streptococcus. Streptococcus is a causative agent for both erysipelas and cellulitis. Okay, and this year in NEET PG 2021 also we have got the same question. They have asked the drug of choice for erysipelas. They have given you an image of acute paronychia and erysipelas, and they have asked you the question. Okay, ji. Let's move to the next question. Which is not seen in Behçet's disease? What is Behçet's disease? It is also a neutrophilic dermatosis, like Sweet syndrome or pyoderma gangrenosum. It has some classical features like orogenital aphthous ulcer. It has some classical lesions like orogenital aphthous ulcer. It has presence of ocular features like conjunctivitis, mebomitis, keratitis. It can have joint complaints, arthritis, and it also have skin features. Please remember the cutaneous lesions which are seen is multiple furuncles or folliculitis, and erythema nodosum ठीक है. Please remember erythema nodosum and furuncle. These are some of the features very commonly seen in Behçet's disease. Coming to the next question. Pseudo-isomorphic phenomena is seen in. Pseudo-isomorphic phenomena is a feature of psoriasis, vitiligo, wart, or DLE. Psoriasis, vitiligo, wart, or DLE. RP, Rameshwar, Tariq, Vidyananda, Purnima, Vedashri, Dr. Priya, Rutvi, Tofik. Pseudo-isomorphic phenomena is seen in psoriasis, vitiligo, wart, or DLE. Psoriasis, vitiligo, wart, or DLE. Please remember the answer is what. Pseudo-isomorphic phenomena always occur in infectious condition because of auto-inoculation. ठीक है. So whenever you have an infective conditions like molluscum, wart, you always develop pseudo-isomorphic phenomena. Ma'am, which all diseases erythema induratum is seen? So this is a question asked by RP. Please remember, erythema induratum is actually what? It is a tuberculid. So the most common infection where you see erythema induratum is tuberculosis. Whenever you have an underlying malignancy, you see erythema induratum. Understood, RP? I hope your doubt is clear. Please give me a thumbs up if you understood this. Okay, ji, fine. Now moving to next question. TB and malignant, ma'am, I have not understood what you mean by malignant. What do you mean by malignant? No, see, erythema induratum is not a malignancy. It is not a malignancy, neither a paraneoplastic condition, neither a pre-malignant condition. Nothing to do with malignancy. There are many conditions like tuberculosis, sarcoidosis, where you have infiltration of the subcutaneous tissue. What is erythema induratum? Erythema induratum is lobular paniculitis. So any condition which causes lobular paniculitis can give rise to erythema induratum. It can be drugs, it can be infection, okay? Any infiltrative metabolic disorders can cause lobular paniculitis, okay? Understood? But per se, they are neither malignant, neither pre-malignant, or neither paraneoplastic. Okay. Now, colloidal membrane is a classical feature of lamellar ichthyosis. I hope you got the answer. This is a classical example of lamellar ichthyosis. You see colloidal membrane at the time of birth, and when this colloidal membrane is breached, you see thick, lamellar-like scales in them. You see thick lamellar-like scales in them. Okay, ji, बढ़िया. Now moving to the next question. A 25-year-old female with nodular acne, hair loss on scalp with increase of central part, the drug of choice is, please remember, the answer is cyproterone acetate. Whenever you have development of acne because of increase in androgen, so these features, the presence of hair loss, the presence of like thinning of the central part of the hair, all these tells you that you are having hormone induced acne, and whenever it is hormonal acne, you have to give something which take care of this excessive androgens. And cyproterone acetate is a drug which is anti-androgen, which will decrease the effect of circulating androgen onto the sebaceous glands. Here we will not give any antibiotics or any oral or topical retinoids. We'll give cyproterone acetate, which will work very well. The next question is here. Can you answer this question? A 9-year-old has multiple itchy erythematous wheals all over the body. For 2 days, there's no respiratory difficulty. Which is the best treatment? Which is the best treatment? Vaishnavi, Taufik, Tariq, Rutvi, Shrishti, Yogesh, ND, Bhavya, Purnima, Gauda, Dr. Priya, Rameshwar, Pankaj, RP. Very well done, all of you. Please remember, whenever you develop urticaria, whether it is localized or generalized, if it is not affecting the respiratory tract, if it is not affecting the respiratory tract, you don't have to give oral steroids. Oral steroids are only indicated when there is respiratory difficulty. So you have to only treat the patient by giving antihistaminic if there is no respiratory difficulty. Clear? What is the treatment of nodulocystic acne? Very, very quickly, tell me the answer. The treatment for nodulocystic acne. Welcome, Om Prakash, Lakshmi, Anupam, ND, Omendra, JK, NSPC. What is the treatment for nodulocystic acne? What is the treatment for nodulocystic acne? Please remember the correct answer is option number 1, that is isotretinoin. The treatment for nodulocystic acne is isotretinoin. It is isotretinoin. Nodulocystic acne is grade 4, and for grade 4 acne, you always need to give isotretinoin. Can you tell me the answer here? An 18-year-old girl presented to dermatology OPD with complaints of acne. Dermatologists prescribe few topical gel, along with that advised for dietary modification like avoidance of high glycemic index food, dairy product. What is the plausible logic behind this? 18-year-old girl presented to dermatology OPD with complaints of acne. Very nice. Please remember, in acne, the drugs or the food agents which we avoid, they are the dairy products and the high glycemic index food. Now, why we avoid these food agents in a patient of acne? Both these agents will increase the insulin-like growth factor 1, and insulin-like growth factor 1 will cause increase in sebum production. It will cause increase in sebum production. In turn, it will precipitate the acne formation. So please remember, the correct answer is option number 1. Clear? Anupam, Om Prakash, Lakshmi, Dr. Pavan, Khushbu, Priyanka, Shivam. I request all of you to please be live every day for these sessions. Very, very important. Now coming to the next. Which mineral deficiency can lead to following conditions? And this will be the last question. Which mineral deficiency can lead to following condition? Very nice. Shrishti, Dr. Priya, Tarek, Yogesh, Pooja, Jayu, Rutvi, Purnima, Rameshwar, Faith, Bilal, Vedashri, ND, Lakshmi, Bhavya. Which mineral deficiency can lead to following condition? Please remember, the answer here is option number 1, that is zinc deficiency. And this is a case of acrodermatitis enteropathica. Acrodermatitis enteropathica. Acrodermatitis enteropathica. Can you tell me what are the other features of acrodermatitis enteropathica? What are the other features? The features are DAD. You have diarrhea, you have alopecia, and you have dermatitis. And in this picture, you can see periorificial eczematous lesions around the mouth and around the genitals. You can see the exfoliative lesions. So this is known as periorificial dermatitis. Very, very characteristic of zinc deficiency. Yes, alopecia, the loss of hair. What is alopecia, RP? Alopecia means loss of hair. So you will see loss of hair in children having the zinc deficiency in them. Okay? So with this, we are done with today's session. I hope everybody have enjoyed this class. And I want all of you to please subscribe to Unacademy. There are a lot more things which are discussed on the Plus platform. So I request everyone to take either 3 months, 6 months of Plus, or they can take a 1 year of iconic subscription using the referral code CHESTA10. Using the referral code CHESTA10. So thank you all of you, and have a good day. I request everybody to please be live every day on these sessions and increase the number of the students. This is the leaderboard. This is the leaderboard for everyone. So RP, yes, you are the first. So bye bye. Take care and good day.